This is the incubator seminar. I'm Alistair Dennison. I'm the director of the NIHR funded incubator in AI and digital healthcare. This is a cross-sector community aiming to collectively advance regulatory science and innovation in AI and digital healthcare. This demand-led webinar series gives us the chance to invite experts to share their work and insights in key areas with us and create an opportunity to dig into these exciting topics and share ideas and challenges together. The format of these sessions holds that in mind, so we'll soon be able to enjoy a presentation from a great speaker today. We'll be in listening mode for the first half, but then you can use the Q&A function, and we encourage you to type comments or queries in the chat as they occur to you. And then we've got ample place for questions discussion at the end of the session. We try to get to all the questions, but we don't sometimes manage. A few days after this webinar, it goes live on our website, so you can rewatch or pass on to others. So, getting to today's talk, in the past few months, we've shone a light on many of the challenges to be navigated by innovators to get our AI and other digital health products to market. Today's talk aligns with many of these questions, and it's about navigating these challenges to take the journey from recognizing a problem in the NHS to getting an AI solution to market. Our speaker today has driven the development and commercialization of a machine learning enabled solution to streamline surgical workflows and support provider organizations in allocating resources to optimize patient outcomes. So it's my great pleasure to welcome Dr. Justin Green. Justin is a clinical data scientist. He's an NHS orthopedic doctor by background, and he's Chief Executive Officer of OPCI. And his title is, Can AI Deliver on the Promise of Reducing Waiting Lists in Elective Care? So Justin, hopefully you can come on camera and unmute yourself, and I'm going to hand over to you once you can share screen.
All right, thank you very much, Alistair. Let me just see if I can share this. First hurdle of the afternoon.
It's looking good.
There we
Yeah,
go.
we've got you.
Brilliant. Well, look, thank you very much for inviting me along to talk about the OpenPredictor project, our innovation. It's been something very close to my heart for best part of half a decade now. Um, and really, I wanted to I started this journey out in terms of working as a frontline clinician, looking at how we could use data-driven technologies to help deliver services in the NHS. And myself and my co-founder, Professor Mike Reed, um, really kind of tried to take that innovation, um, grow it, scale it, provide it as a tool, for the benefit of patients and the health service. So, um, thank you very much for inviting us. This is a real privilege to be able to share our journey, but also, some of the challenges around it. Um, so I just wanted to kind of provide a brief overview in terms of the webinar this afternoon, really kind of highlighting some of the global challenges, what drove us to start this journey all those years ago, um, and why we chose machine learning, why OpenPredictor came into creation, um, and why that really matters to patients. Then just would like to show a bit about the OpenPredictor tool, the information that we use, how we went about kind of building those models and generating the evidence to show that they were effective, but also, the practical steps of how you then integrate that into a clinical workflow. AI is a new novel technology. A lot of clinicians, both home and abroad, are working to how they integrate it as a useful tool. And then one of the benefits, really, I suppose, of where we've been is that we were able to now start to generate evidence that there is efficacy in real life performance, that using OpenPredictor has got some benefits. Don't want to spoil the conclusion at the end, but we see that there's an opportunity there. It's not easy, but there's definitely some benefits to be had, and it's not always straightforward, but hopefully you'll get a flavour for the journey that we've been on. So just setting the problem itself, the this is the health service kind of globally is facing challenges around populations which are getting older, increase prevalence of chronic diseases, which goes hand in hand to that. Um, and we're still battling with challenges around the workforce, short-staffed, patient, nurses, doctors working longer hours to deliver the same level of care to a swelling backlog of patients. And what we saw is, particularly in elective surgery, that process gradually building over a number of years. When COVID happened in 2020, we saw that there was a cessation of elective surgical activity for a prolonged period of time. And we've really struggled to make headway in recovering that. This is multifactorial. It's not just down to staffing, it's not just down to population, it's down to the fact that patients that are on waiting lists for an extended period of time start to deteriorate. So it compounds the challenges that the health service needs to work with. So Mike and I really kind of wanted to distill these um, these challenges into really kind of three areas: that the efficiency of workforce force and delivery of care, and also um, how we kind of take patients and allocate them into services that enable us to do more operations safer, and rationalize those scarce resources around medical high acuity hospitals for patients who needed it the most. Looking at how we do that, that's currently undertaken by clinical teams. Um, but as I said, the population and the demand is increasing, and that burden of clinical workforce is getting more. Um, so could we take these challenges and could we address them with data-driven technology? And specifically taking these for elective, so non-emergency operations around arthroplasty. So my background is, Alistair said, as an orthopedic doctor, was really kind of focused on um, total joint replacements. This is a big chunk of the waiting list of patients. Um, and we've got huge waiting lists, some patients waiting over years, 2 years for their operations. One of the benefits of the operations is it does certainly lend itself to pathways which allow us to have lower acuity, lower staff levels of staffing in hospitals that are purely designed and built for elective services. So looking at um, joint replacements in smaller community or rural hospitals enables us to enables us to push through bigger volumes of patients and enable and get those patients through their operations faster. So this process, this ability to develop high volume, low complexity pathways is really important to be able to making headway in those waiting lists. Like I said, it keeps the high acuity hospitals, the bigger hospitals, available for those patients who need it, who have greater demand in terms of post-operative healthcare. I said that patients on waiting lists um, compound the problem. The longer they wait, the bigger the problem is, which is contributing to um, our backlogs. And this paper was released, it's a couple of years ago now, but what it identified was using the EQ5D metric, which details kind of patient reported outcome measures. It showed that patients with prolonged periods of stays, prolonged time on waiting lists that weren't going in for operations were deteriorating in terms of pain, in terms of function, and their ability to have a decent life. Um, to the point that about 1 in 5 of those patients reported an outcome measure which was essentially worse than death. So, this is really kind of illustrative of the challenge that we're facing around those mounting pressures around those backlogs. So this was where we brought into the program OpenPredictor. Now, OpenPredictor at its heart is an AI tool which is used to identify patient level of risk, so predict risk of non-emergency surgery. And we brought this in to use and develop this in-house in the NHS initially to look at how we could identify patients which were more suitable for those HVLC pathways, so those high volume, low complexity pathways, by scanning and scouring medical records. And if we do that, we could identify patients who are more at risk and less at risk of elective surgical anaesthetic. The idea really was to try and improve those outcomes for patients, get patients into operations faster. But as we started to employ those different approaches in terms of machine learning, we're able to break down some of those risks to make them much more personalized to individuals as well. So this gave us that ability to create a personalized risk profile for patients undergoing elective surgery. So this is a bit of a schematic in terms of how it works. Very high level, and a referral for an operation would come into the hospital. Um, we can take that information, we can extract and augment it from the electronic patient record, the EPR, and it can be processed through the algorithm, the platform. Um, because OpenPredictor is in the cloud, it can be scaled. We can process one patient, we can process 10,000 patients. It's got that capacity. And then each of those patients that are processed are provided with this personalized risk profile. So this output report, which gives them an indication level of risk of anesthetic for their operation, whether they're classified as moderate, low, moderate, high, but also breaks down that risk into the compounding factors. So this really helps the teams around pre-assessment to review those records. Now, this process is something which is done ordinarily as part of the pre-assessment team, but it tends to take about a 40-minute in face-to-face appointment. Whereas one of the benefits of using the cloud is that you can do this process quite fast, so less than a second. And that information, because again, it can be collated across a whole waiting list, can be used for that demand and capacity planning for the hospitals. So getting patients into operations and identifying site of service. The information that goes into the modeling is really what one of the challenges that we looked at quite early on was ensuring that the data that we used was standardized. So it was consistent across all healthcare providers, NHS providers initially. Um, and we didn't want proprietary or information which was going to be difficult to obtain. So we spent quite a bit of time looking at the structure of the data, where it comes from, and we pulled out factors around demographics, so very standard information which is available, patient age, sex, but also looking at those comorbidities that they have based on national frameworks. So we use the ICD-10 codes, and we've mapped that onto FHIR HL7 in terms of our inputs, the information that's required to run the model. We've also looked at standardized laboratory tests, so blood tests that are brought in. Again, nothing which is uh, untoward. We wanted the information to be able to be ingested. So every hospital was able to produce it. And when we were looking at the outcomes, we wanted those outcomes to be readily recorded as well. So standardized outcomes. So in essence, what we looked at was demographics and comorbidities, and we were trying to predict those outcome events based on a series of complications, nationally coded complications, but also any post-operative events such as readmissions, returning to theatre, prolonged length of stay, and mortality as well. So using standard data inputs to identify relatively standard complications, outputs from surgery. Um, we recognized quite early that the that doctors, clinicians, nurses are quite often overloaded in the health service with tools and new programs to log in with. And so it was very important to us that we'd spent time understanding where OpenPredictor fitted in the clinical pathway, in terms of that patient journey, but also from a staffing perspective. So we worked with clinical teams in Northumbria, down in South Wales, to really kind of map out those clinical pathways on a day-to-day, how that information flowed into the hospital, who was required to see it when, but also where we could fit in terms of providing added benefit. And this was one of the program. This was, very, very high level schematic in terms of an operational pathway for elective surgery, where a patient would ultimately have a couple of touch points along the way before their operation. But at each level was an opportunity to introduce OpenPredictor to provide added information around risk score, likelihood, and suitability for surgery. And at each point, we could be able to run the program quite quickly up in the cloud, amend it or append any additional information, and provide an updated score. And therefore, that would provide a bit of a profile of risk as those patients move through that pathway. The benefits back to the pre-assessment teams was that they could actually split out those pre-assessment pathways. So they now have the ability to run patients through different pathways, and move them up and down these swim lanes. So as a graphical representation, not all patients would, most patients previously would kind of come in on that, probably that bluer type pathway, if not the red one at the bottom. But introducing OpenPredictor, giving information around patients that were suitable for lower risk, high volume, low complexity pathways, enabled those providers to be able to move patients up, and reduce some of the medical contact. What that meant was that the higher risk patients are able to be really focused on by the pre-assessment team. So they can bring them in early, they can identify risk, bring patients into the hospital for medical optimization. This was a case study which we've had down in Wales, which concluded a few months ago. We've had permission to share this. What we looked at here was patients that were awaiting primary arthroplasty with over 2 year waits. So these patients have been on the waiting list for 2 years, and we were looking at how we could stratify them and identify cohorts of patients suitable for those HVLCs. At the time when we looked at this, there was just a very, very big list of patients that were waiting, and they were getting seen in order of how long they'd been on the waiting list. There was a big push to try and reduce the number of patients that had been waiting 2 years, and so the health boards in the area were looking at opportunities that they could to identify those patients, identify those which needed to come in for another pre-assessment, so face-to-face appointment and medical optimization, versus those that they could kind of direct towards outsourced services, so the private sector, really to try and make some headway. And what we found was that we ran about 3,000 patients uh, over the course of about 6 months running OpenPredictor, and it was able to accurately distinguish around half of patients who would be suitable for those HVLCs. So this was us being able to look at a patient's record, identify if they had any major red flags around elective surgical pathways, and if they didn't, categorize them as low risk. And those patients that were low risk were then directed towards external services for pre-assessment and their operation. And if they were deemed to be low risk and suitable, then they would progress through. And if they weren't, they would come back and be flagged as, inappropriately directed towards those HVLC pathways. Um, and this process, so the results of that were really promising for us because we although we identified, it was just over half, um, most of those patients did in fact have their operations in those high volume, low complexity sites. So it reduced the burden on the hospitals of having additional pre-assessments and time with patients who didn't really need it. So significant cost saving for the healthcare providers, but also those patients were pooled for the outsource for the high volume complexity sites, low complexity sites. Those who were deemed were high, which is that little blue wedge on there, 30%. Those were prioritized for in-person pre-assessment path reviews, and that meant that they could spend more time with those patients, getting them medically fit, and reducing the likelihood of them having an adverse event post-operatively. So this was really kind of, we wanted to kind of build this into a model, which was how we promote, prevent, and then prepare patients for elective surgeries. And this was modelled a little bit on pyramid from the Welsh government, but what we wanted was to be able to show that we could provide patient level information in the form of individual risk profiles based on medical records, and we could do that accurately and consistently, and that we could run those profiles time and time again, so we could build out a picture over the course of that patient's waiting time based on their health requirements. We wanted to be able to show that we could support the health boards to deliver to deliver pre-assessment services in a renewed format. So not one size fits all, but could take the opportunity to identify using those cohorts of lower risk patients, introduce lighter touch pre-assessment approaches, and we wanted to support the pre-assessment teams to be able to look through those patient records that were on the long waiting list and identify suitability for those lighter touch pathways. Um, and then from a waiting list processing perspective, um, being able to identify high risk patients that could come in for early pre-assessment and healthcare optimization will help to prepare them for surgery and increase the throughput of patients on the waiting list. So saving the high risk ones for the big hospitals and the low risk ones for the smaller hospitals. Um, so this bit of a busy slide, but really what we were showing here is when we then did our work in conjunction with the pre-assessment team. So actually running OpenPredictor and the technology prospectively, what we found is that it was very good at, well, it was good at identifying patients' suitability for different sites. So those high risk ones were very much deemed as high risk by the clinical teams, and the low risk ones were largely suitable for the high volume, low complexity pathway. And I often kind of talk about this slide with a sensitivity of 80%, saying, well, that's not the 99% that we tend to hear about in terms of performance of AI models. And I think you're right. I think we're not at nine. Well, we're certainly not at 99%. But when we looked at the clinical teams, their sensitivity on identifying levels of risk in patients, their pre-assessment risk, it was around 70%. So it's very difficult to identify and to judge a patient's level of surgical risk from the onset before they have an operation. There's lots of factors intraoperatively, there's lots of factors postoperatively which contribute to it. But from a pre-assessment, from a predicting whether or not a patient's high or low risk side of things, I think it's fair to say that that we are at least as good as a clinical team in terms of identifying those patients. So there's a real benefit there for a hospital in being able to provide uh, essentially a tool which can work alongside or as a second opinion in terms of clinical assessment. And then this was how it kind of fitted into the pre-assessment process from in Southwest Wales. So this is our proposed use of OpenPredictor and where it's sat. And you can see those green bars are each time that OpenPredict could be run, providing that longitudinal profile of risk for patients. Um, one of the things I think which was very important for us was being able to show that there was a tangible output in terms of patients. So still working through the process of gathering information on patients that have gone through the operation, and that will take some time before we get those any clear figures back. But alongside that, we were very fortunate that Dr. Alan Price from Swansea University Innovations was able to look at some of the economic benefits of running OpenPredictor as a service within the health boards. And we've been able to take that information and put it onto a website, which is accessible, so anyone can go through it, and model some of the outputs that OpenPredictor would have on a healthcare provider or a trust, an NHS trust that's not running OpenPredictor at the moment. Um, I mean, in summary, there's a lot of benefits to be had just by reducing those unnecessary in-person clinic appointments, um, by identifying, in this case, that 54% of patients who didn't need to see someone face to face time and time again. And then the other side of it is that once you start to save time and save effort, money from uh, those unnecessary appointments, that time is then given back or recoverable by the health provider in terms of nursing time, doctor's time. So they can be then used or kind of directed towards additional facilities and services to run. So for us, taking a nurse and anaesthetist out of half of the unnecessary pre-assessment appointments that they're sat in means that we can put them into theatre and we can do another operation at the same time. Improve that the number of procedures that the hospital can actually carry out. So this was the summary of OpenPredictor in Southwest Wales. Um, this was a story written by the Life Science Hub down there. Looked at the stakeholder engagement, looked at some of the outputs, but in essence, really demonstrated that there is an opportunity for data-driven technologies for AI to deliver efficiencies in, particularly in elective surgical pathways. Being able to embrace that and take that on was, a great privilege for us to be part of that, working alongside those clinical teams and the hospitals to demonstrate that we can do things a little bit smarter and we can get some benefit out of them. Um, no kind of system or services is complete without the regulatory and compliance side of things. So particularly using AI in healthcare, there's a lot of work that needs to go on around justifying the demonstrating that you have built models in a safe way. We've gone through the process of a Class 2A certification with the EU MDR. We're currently just in the final throes of our second part audit for that. And luckily, there's no big flag so far, which is great, but it has been a lot of work to be able to demonstrate that we've spent time validating and verifying each part of the process in terms of the software as a medical device, so the AI modeling. There's a lot of information that's been provided around how we built the data sets, how we tested those models, and some of the things we can't account for, those biases and those ethical considerations which we need. And so, really, this brings me on to some of the challenges that we faced in developing AI systems. So, the fact that we were looking at initially quite large data sets, but very historical, meant that we were amplifying some of the challenges around data consistency, data access for different groups in the population. We've always known that there are barriers to accessing healthcare, and one of those aspects was that the information we found was very very heavily weighted towards the more affluent, wealthier, dominant population groups, and minority groups that perhaps were not, that did not have English as a first language or had, or were from more deprived backgrounds, were less represented in the population. Um, I think the other part of this was that, you know, when you're developing these models, you're very conscious of the teams that you work with, um, and and just because of the approach that we take, we're very much in the health service. We're working with professionals. There is the potential there to kind of accentuate biases because of the team dynamics. Um, I think we can do what we can to mitigate that, but the main point is being aware that these are some of the challenges. Very fortunate to have worked with some incredibly gifted data scientists, proper data scientists, and introduced components such as Shapley modeling to Shapley coefficients to help try to break down some of those input variables so we could understand the impact they have on our predictions. This really helped twofold. First, to kind of clarify how the models were working, but also it enabled us to be able to introduce that information back to the clinicians and the patients so that they could see, why a model was telling them they were a particular level of risk. So that explainability, very important in terms of being able to kind of show our workings, for want of a better phrase. But yeah, but we did run into problems, and those potentials for harm, and I think we needed to recognise that there is a danger that although we predict outputs, we predict patients' likelihood of risk, um, there is a possibility that we're, we're predicting um, our predictions aren't right, and that we can potentially kind of create problems around provision of healthcare. So for us, being able predicting someone as low risk who was in fact very high risk, and enabling them to move through a system without any checks and balances, meant that there was a level of risk associated to the application which we needed to be able to account for. So being able to flag those patients internally using the clinical teams to identify those as erroneous results, and then going back through and spending time reviewing those to understand why they were predicted. And I think to date we've caught one person who scraped under the barrel as scraped under the threshold as a low risk patient, for for but was deemed actually quite a high risk patient. And it turned out that when we started to kind of look into it forensically, we were seeing that they had just small incremental gains across the board, but nothing which really stood out, which would tip them into the high risk category. And then this is one of the other challenges which we faced, and I want to draw your attention to this little dot here around smoking. So this dotted line is essentially the baseline in terms of risk. Everything above this line is some of the positive contributing factors to risk. So these will increase your risk, and anything below the line was deemed as a mitigating factor of risk. And there's 2 points here: smoking and frailty of old age. Now, what we actually found was that the data showed that if you were a smoker, it reduced your risk. but in reality, smoking was so poor and such a detrimental impact in terms of health, patients were screened out long before they ever got through to operations because of smoking. So the only patients that we had that we looked at with smoking history were those that were fit enough or well enough to get through an operation without a complication. So it's a real red flag, but being able to identify that and having clinical knowledge around that as well as the data knowledge is really important. And then of course there is always those age biases in our models as well. So uh, even we have a test in orthopedics, which rather jokingly is called end of the bed, where you walk in and you look and um, eyeball someone to see whether or not that you want to do an operation on them. Um, and typically that correlates almost directly with age. And we've got much more objective measures as well, but this that's our end of the bed test. Well, it turns out models do something similar. So as you become older, models tend to group you into higher risk categories regardless. Um, so that's some of the work that we've done. Where we at the moment, we're really fortunate that we've got a couple of programs where we are kind of uh, pushing OpenPredictor to be used around elective surgery. We've looked over to the US and have developed a pilot over with Michigan. Um, and we're really fortunate to have been able to be nominated for a couple of national awards over the year as well. So I'm going to stop there. That's my time. Thank you very much indeed for listening. I'm happy to take any questions.
Thanks so much, Justin. That was brilliant. And yes, please do put questions in the Q&A function. Um, um, just a couple of questions from me, Justin. What would you do differently if you could have your time again on this?
What would I do differently? Gosh.
Yeah, because what occurred to me is hearing you is that you were telling us the journey of the technology you're building, but I think it was probably the journey of you as an innovator as well. And so there will be things that, I mean, the amount you've learned on that pathway. Yeah, if you were kind of starting up, with a new model, a new tool, maybe.
Yeah, I mean, flippantly, I would say stay away from healthcare, which,
Yeah,
uh, um, and I think that I say that half jest in jest.
yeah,
We built our model because we really started as healthcare providers looking at how we could use data to improve the service that we were delivering. So we were looking for a way to benefit our patients and to improve
mm,
outcomes. I think that approach has done us very, very well because it's enabled us to really kind of build this from a clinical need. So identify an unmet clinical need, build a solution, build a tool that addresses that. Spent a lot of time kind of trying to tell people that AI is not the solution along the
yeah,
way when I was in the NHS.
mm,
And now we're at the point where we've got it so it's running at a level which makes a difference.
yeah,
And that's for me, that's been great, that journey. I think if I was coming at this again from the start, I would have chosen an easier topic with a more readily available consumer base
yeah,
because there are lots of challenges around stakeholder engagement, clinical evaluations, clinical data, the IG, the information governance of it, the data security of it, all of that has been a lot to get through. Um, and I think we're there, but I think that I certainly think there are easier ways of becoming an AI innovator.
Yeah, I mean, it's a recurrent theme of these webinars is the number of different gates there are between, the great idea and you actually being able to um, for it to be used and for you to be able to sell a product, basically. Yeah, no, nice point. I'll just go to some of the questions in the Q&A and the chat and so on. So nice question here. Thanks so much for sharing such interesting work. Could you perhaps share whether there was any friction from clinicians and or patients into trusting OpenPredictor's risk assessment? More broadly, are clinicians and or patients open to adopt AI as part of their health workflow?
Yeah, I think they are. We have very little resistance from clinical teams around using AI. I think we've got a workforce which is really stretched, really challenged. We see the benefits. We all see the benefits in the potentials around using AI. I use that as a very kind of broad term,
Yeah.
but those data-driven technologies. And we've got a lot of clinical teams who are very kind of keen and engaged in the process. There are lots of papers, there's lots of reviews, there's lots of evidence being generated around tools and services and research. Clinical teams tend to be quite forward thinking and proactive. Our biggest barrier, I would say, is the integration into infrastructure and hardware. And I think what we've seen is that we've got a clinical team that's ready, that's desperate to adopt. We've got an executive team and NHS leadership, which is really trying to drive it, but we're still battling with a fragile infrastructure that's either expensive or largely locked down to single providers. And we've got challenges around data, patient record and
Mhm.
information being consistent and full. So I think main challenge for us, and I suppose I see it with my peers as well, is around actually integrating and using it as a tool within the NHS because of that infrastructure.
Yeah, no, I can't disagree with that. Um, Another question here. Lots of predictive models are published as papers or even apps and end up being used without going through medical device regulation. How much risk do you think that poses for patients? And what are the advantages of putting the work in to get your product certified from a developer perspective?
So I think it poses a significant risk. I think we've got a lot of tools which are coming on to the market, proclaiming to be, you know, whatever level of functional accuracy, being able to do something. And there's no real evidence behind it. They're behind, commercially sensitive data repositories. There's very little information around the technical build. There are there's regulations that require self-certification or self-declaration, which on the whole, you know, we've got no visibility over those files beyond the fact that someone submitted a conformity assessment.
Mm,
I think unfortunately we're in a state where not everyone, but there will be a small minority who will be pushing and deploying tools on 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 false pretenses.
yeah.
Therefore, I think those requirements around external validation, um, reviews and audits that you've built a product safely, that you've got evidence that is consistent with what you're claiming, is very, very important. And I think what we should, it takes a lot of work, and unfortunately, there's a bit of a bottleneck there. But I think with the interest of patients, we need some way of demonstrating that the tools we're using are safe,
Mhm.
and do what we say they will do.
Yeah, no, thank you. So much to say on this one, but no, that's helpful. And another question in. Uh, Uh, it's so interesting what you shared regarding the AI model not learning smoking as a red flag for high risk learning age or learning age bias. Does OpenPredictor address these bias learning, and are you continually updating the model's predictive accuracy?
So we part of the software as a medical device is that we have to submit our model in the state that we've tested it for.
Mm,
So that one process is that those models can't continue necessarily be updated directly. We need to go back, gather evidence to show that any updates improve the accuracy. Um, so it's not a continuous learning process, but with regards to the smoking side, yes, part of it, because we recognize that we need to put in that as a risk into the platform, into the model. So we have those flags that are included that when there's a smoker, those flags that information is flagged, and we recognize that the model has a tendency to underestimate risk with smokers, particularly if they're coming in. So
mm,
so I think once you start to identify these things, you need to make sure that you've included them in your risk register, that you understand how it's going to impact clinical
mm.
assessment, and that you've got safeguards within the application or the platform to identify them.
But how do you manage that tension, which is kind of a spin-off of this question between learning as you go and wanting to update the model, whereas you quite rightly said that you kind of you effectively fix the model at the point you've applied for regulatory approval. How do you manage that? And yeah.
Yeah, I mean it's part of it's that post-deployment surveillance. So
Mm,
that ability to go back, review who's been processed, look at how they tally to, in our case, clinical assessments, how what their outcomes were. Um, I mean, there are predetermined changes in terms of the compliance side. So if we know that we're going to be introducing factors to the model, we can have a controlled change plan that enables us to be able to update those as part of that process. Um, but I think this is an iterative process. This is a process that you register it, you have to have the evidence to make to the claim that you're trying to do to say what you want the program to make. And you need to also have that agreement with the healthcare providers, in our case, to continue to gather data and to continue to kind of review the programs themselves so that you can measure the impact. And if that means that you can improve the model's performance at a later date, that needs to be included as part of that process and as part of that controlled change plan. So it does change. It's got to be a measured, structured approach to changing the model's performance. It's not we found something new today, so let's just drop it in there tomorrow kind of.
yeah, yeah. No, nice. And probably last question before we close. Um, So obviously you had insight as a clinician working in this space in terms of the issue that you were the sort of unmet need and the issue you were trying to tackle. But how much did you therefore go, I know there's a problem here, and then plow ahead? And how much did you sort of do market research to get a sense of whether there was actually pull, as it were, from the market for this?
Yeah, it's a good question. So we did a lot of market research through networks. So I touched on it previously, but when we first started out, the model performance wasn't very good at all. So I would talk at various NHS conferences saying, how we just weren't there. We didn't have the information, the function of the models were not good enough. And that gradually kind of progressed as we built them out and managed to kind of improve the accuracy of them. But all that time we were talking to clinical teams, directors, clinical leads around, what would benefit, how do we need, what would benefit them in terms of delivering care, what are the biggest needs for that would help to get patients into operations faster. And each time it was coming back with, it'd be great if we could identify patients for high volume, low complexity pathways. It'd be good if we could do that quickly. So there was a lot of kind of discussions around people that were involved in that part of the care pathway in terms of their needs. And then since then, as well, we spent a lot of time with the users gathering feedback in terms of the application. So some changes we can make in terms of its functionality don't necessarily impact on the software as a medical device. But again, it is a process. What we found largely is that there's some core requirements across the NHS, and then every hospital group that we speak to has got their own nuances on top of that. So, they may have something specific to them that another hospital doesn't necessarily use, but you have to balance that in terms of your development.
Brilliant. Well, on behalf of all of us, Justin, thanks so much for really great talk and discussion. That's it from us for this year. We will reconvene in January. Do make sure you've registered with the incubator so you get advanced notifications. Also, let us know if there are people that you particularly want to hear from or subjects you particularly want addressed. And we look forward to seeing you in January. My thanks to you, Justin, and thank you to you all for joining today.
Brilliant. Thank you very much. Thanks. Cheerio.